Hi, I'm Larry Mike Garindo. Welcome to this edition of Excelsior Foreign Profiles. And back with us for part 3 is Dr. Vaksha. Dr. Vaksha, thank you so much for coming back. So many viewer questions. I didn't realize so many people had these back and neck problems. So hopefully you're going to explain a little bit more. Last time we got into some of the diseases and problems. Now we're going to get more into the cure, the surgeries, and what could be done with some of these things. Now, we did get a couple of viewer questions, which we are going to answer during the program. But the first one is can sciatica develop into stenosis?
Yeah. First of all, it's my pleasure to be here with you, Larry. And I will be answering all the questions that we have today. So sciatica is caused because of the pressure on the nerve roots in the lower back. And this may be isolated presentation of a disc herniation or a cyst, but this can be also a part of stenosis. It can be a presentation from the stenosis, though the stenosis may be mild or moderate to present with, but causing a compression on a specific nerve roots causes the sciatica the pain. On the other hand, the stenosis, if it gets severe, can compress on multiple levels and can cause presentation of stenosis along with the presentation of sciatica, maybe at 1 or 2 levels.
Now, what exactly is stenosis, just to re-verify what we went over before?
Yeah, so stenosis means that the canal size has decreased. Anywhere stenosis, maybe in an artery or spinal canal, that means the size of the lumen has decreased. So stenosis in the spine means the canal size of the roots which they are going through has decreased. And that decrease in space causes pressure effect on the cord or the root where it is, causing the problems to come on.
So basically, it's as if, to explain it in more lay terms, is if you had a half-inch pipe that was running, which is the nerve. Now all of a sudden it's down to 1/4 inch.
Yes.
Because of compression. So what's happening is that nerve is being squeezed, and eventually, like any electrical wire, if it's broken or squeezed off, then there's...
Exactly. And in this condition, when they get squeezed, the issue is that they don't get good blood supply. And when they don't get good blood supply, the nerve tissue goes into ischemia, and ischemia causes varied symptoms of pain, tingling, numbness, even weakness, involvement of bowel, bladder, involvement of gait, and all these things.
Yeah, which gait, by the way, is the way you walk.
Is the way you walk,
In case
yes.
people aren't thinking we're talking about their PVC
Imbalance,
or something like
yeah.
that. Now, when is the time for people to visit the physician's office with these neck and back problems?
Patients may have a neck and back problem all the time over their lifetime. Again, the incidence of spine pain is 60 to 80%. Most of these people don't need to visit a physician. They can get treated by themselves. Very short period of rest, taking some anti-inflammatory medications, using some ice and heat, and they can get back to their normal routine and work. Over their life, I would always suggest that they should keep themselves fit, especially with regards to the muscles of the neck and back, doing core strengthening exercises as a part of their daily routine, maybe at home, maybe at the gym. Now, there will be a very small subset of people who will not get better over time, and these people may need to visit a physician, their primary care physician or a pain physician. There will be a very small subset of people who will also have pain radiating down their legs or arms, depending on the location of the problem. And they may need to see a pain physician, maybe their primary care can help, or a spine physician, spine surgeon can help these patients.
Now, when is it the time to visit the ER with a back problem? Is it you can't walk, total numbness? What are the symptoms? When should you go to the ER?
Exactly. Not every patient should be visiting the ER for a back problem. But if they have very severe back pain that they are incapacitated at that point of time, they may visit an ER and they will be helped with some pain medications. But the patients who can be really helped in ER are the patients who develop sudden onset worsening of their neurological status, like weakness in their legs or unable to control their bowel or bladder. They are either retaining urine or they are incontinent. They just can't control their pee. Or they have numbness around their genital areas. These patients may have some very serious pathology in their spine, and these are on a timeline. They should immediately reach the hospital. They should be treated possibly they may need a treatment immediate, they may need a surgery to get better or at least stop the process which is making their neurological status to worsen.
Again, going back to what we said before about that nerve. Now, with a vein or muscle, something like that, they can maybe cut, restring, and everything. When a nerve is broke,
Yes.
that's it. And until they can rewire the body, and the majority of controls, like we had said in the last program, are that lower T1, L1 whole area, and it's kind of scary. And a lot of people who have saw the show, other previous programs that we did, had wrote in and were like, panicking and stuff. So hopefully, we could relieve some of that, from them, realizing that, if you're going to go to the ER, it has to be, or should be, some real drastic problem, nerves, can't walk, lost all feeling in legs. Again, this is that centralized area of the spine that we were talking to. Now, when people have this type of problem and they come to see you, what kind of surgery procedures can you do to, bring this back to them?
Yeah, so patients who have back problems, who have sciatica, complaining of pain in their legs, tingling or numbness, these patients are initially treated without surgery. So we treat them with medications, we treat them with physical therapy. Sometimes they can get cortisone injection in their back, depending on the location where it is, and it can be an epidural or a nerve root block. And these patients get better. Actually, 90% of these patients will get better without surgery. But there is a 10% population subset, and we don't know which subset it is, which patient will develop that, which we need to surgery or not. But these people will not have any relief with these treatment modalities and will need surgery to decrease their pain, to improve their lifestyle functioning and get back to their life. So we perform various types of surgeries in these patients. They vary from a small surgery like decompression or discectomy to a bigger surgery like fusion, depending on their presentation, depending on their findings, on their imaging, depending on what other pathologies they have.
And we had already spoken before about the new discs that are out there, disc replacement. One question we didn't answer, though, which came up, was, do genetics play a factor with these back problems? Like grandpa had it, my dad had it, I have it. Is it really genetic?
Yes, so recently our studies have found that yes, the genetics do affect our body composition and disease process, especially on the spine degeneration and arthritis. And there has been found a positive correlation between families over time developing stenosis or over time developing degeneration of the spine, lumbar spine, and presenting with various pathologies.
So it's a big yes on that one, right?
It is.
Now, we had spoke before. You had said about injections into the back. What type of injections could you do for somebody who's having some of these issues?
So when patients present with pain, which is especially going down their legs, in the form what we call sciatica, we do try to treat them with cortisone injection. It can be done by spine surgeons. It's usually done by pain physicians also. And they are essentially of two types, epidural and nerve root block. Though we can do facet block, we can do trigger point injections, SI joint injections sometimes are needed for these patients. And these patients, these injections try to focus on a specific point, specific area to reduce the inflammation, to reduce the pain. Many of the patients get good relief after this, and those who get good relief may never need to get any other treatment done after that.
So it does work out. So some, it can be a cure-all, but then we have others where they've let the problem go, like you had said before. You having the back problem, I'll take a couple of pills. Now you've had the back problem for 6 months, 8 months, not realizing that compression of that nerve is getting worse and worse. Now your sciatica could be stenosis, and it could develop into worse things. What other options after surgery? What are the good results that can come from surgeries for the back?
So surgeries done for these indications, what we do is decrease the pressure from the nerve roots or nerve roots, depending on where the compression is. By doing a discectomy or a decompression surgery, we take care of the pressures, that gives good blood supply to the nerve roots, that causes the relief in the symptoms, and the patient can get back to their normal life, activities and activities of daily living. So that's what the surgeries help with. Over time, even after the surgery, they have to keep their back fit, because the degeneration process can still go on that level and on other levels too. And so to keep them away from further treatment options or treatment like surgeries, they have to keep themselves fit. Now, there is a subset of patients who may also have some instability of their spine, which we find out on imaging. And these patients may just not need just decompression surgeries, but may need to have a fusion surgery also on their back, in which we do is we fuse the segments of the vertebrae which are unstable or which have the problem by use of multiple modalities like cages, rods and screws, using bone grafts. We can go from the front, from the back, from the side. So there are multiple ways that we do this.
Now that was going to be my next question, because a bunch of viewers wrote in to find out when we had mentioned on the program that not only can you operate on the spine from the back, but you can also operate on the spine from the front. Kind of like really blew everybody's mind. Can you explain a little bit more about how that goes between the front and the back?
Yes, exactly. So most of the spine surgeries on the lumbar spine on the lower back are done from the back. But there are occasional in patients who are good candidate, we need to go from the front and do what is called an anterior interbody fusion, in which we clean the disc up going from the belly, clean the disc up and put a big cage or a bone graft there. And many of these patients, we have to go back also still to put the screws and rods, which we can do with the minimal invasive surgery. And these patients do really great. Some of the patients who do not need to go from the front, we can do similar procedures from the back also, and sometimes from the side.
Now, some of these surgeries that you had mentioned, I want to get a little bit more into this. You mentioned spinal fusion. So the first thing people are thinking about is like welding two pipes together. Tell us a little bit about that.
So spinal fusion is something like welding two pipes, but in this case, we are just welding the two segments of a mobile spine. We leave mobile segments above and below. Now, we can do a spine fusion on one segment level or multiple, depending on the pathology, depending on the need for that procedure there. In this, fusion is essentially type of creating a fracture there so that the body mimics in healing the fracture. And we create the biology around it by fixing it with the using of rods and screws and cages so that it does not move, at the same time putting down bone graft so that the body stimulates more union there.
Now, besides from the fusion, what other back surgeries are there?
So the patients can also be a candidate for a non-fusion surgery like disc replacement. Now, lumbar disc replacement is not as common as a cervical disc replacement, but still can be done. The patients who are a good candidate for lumbar disc replacements are patients who essentially have just back pain and have failed all treatment modalities for at least 6 months. It means they have tried physical therapy, medications and everything, and then we have an unequivocal imaging saying that the disc, one single disc or two, are a problem. In such cases, we can do a disc replacement also. There are certain other surgeries that can be done, which are non-fusion surgeries for patients who are really old, like we put interspinous spacers in patients to take care of their stenosis and at the same time doing minimal damage to them. But in most of the non-fusion surgeries that we do is essentially decompression, in which we take the back part of the vertebrae called the laminectomy, clean up all the nerve roots so that there is no bad tissue around them which is compressing on the nerve roots, allowing them good blood supply and good environment to heal, to recover from the pain, from the tingling, the numbness, balance problems and others.
So you can do replacement on the lumbar spine as far as the disc are concerned?
Yes, it can be done. The selection process is a rigorous process for a lumbar spine disc replacement, but it is done and it's a successful surgery.
Now, and again, that goes back to what you were saying about, because people think discs like frisbees or something like that. And these are like gels, actually, right? They're
Yes.
not like hard pieces of bone. They're like gels, it's things that bend and move, right?
They are cushions between the two vertebrae. They allow movement to a certain degree. At the same time, they act as shock absorbers. And that's the reason that a spine is mobile, that we can turn our heads, turn our body, bend it forwards and backwards, because of the discs.
Now, spinal problems like from car accidents have to be the worst, because the body it's thrown forward and then it's thrust back, and that so much pressure on the spine. And a lot of people who are in these bad accidents really get some serious problems. Have there been any new technologies to like help these people, like their spines are almost dislocated or broken, or can it be mended?
Yeah, so many of the patients who have these car accidents have injuries to their muscles or ligaments, and they can be treated without surgery by physical therapy, medications. But those who have fracture, who have dislocation or subluxation, they may need surgical treatment in the form of, again, fixation of the spine, fusion. There will be patients who injure their disc or the facet joints or ligaments during these accidents, and who don't get better with a conservative treatment. These patients may also need some surgery in the form of discectomy, decompression, foraminotomy, or fusion surgeries. We also have recently come up with laminoplasty of the lumbar spine, which we also do in the cervical spine also, in which we try to do decompression with causing minimal damage to the back muscles and the bone there.
Now, you had referred to minimally invasive surgeries. What's minimally invasive? I mean, it's like a 2 or 3 hospital day stay? Is it an in and out? Is it outpatient? What is it?
So minimal invasive surgery essentially means doing the same surgery that we want to get the same result or better, but going through a channel or a opening in the skin with minimal damage to the nearby soft tissues like muscles. So it may be not a smaller incision, but it may be a little smaller incision, but we try to give less damage to the tissue around. Now, minimal invasive surgery can be done using microscope, using tubes or tubular surgeries, or using endoscopes. And we try to do minimal damage as the surgery itself says, and go on to the site where the pathology is and take care of the pathology, the problem, cleaning up the nerve roots, cleaning up the stenosis, so that the patient get good relief, by the same time less morbidity. This allows us to send the patient home early, maybe the same day sometimes, maybe the next day, and at the same time it allows early recovery for the patient, shorter physical therapy period, shorter recovery period, and coming back to their normal living.
That was my next question, was about the recovery time with these minimally invasive surgeries. Recovery time is like in at 8, out by 5, some of the stuff, right?
Yes, exactly. So some of these surgeries can be done on a day basis, that they can be operated in the morning and sent back home the same day. And after that also the recovery period is cut by half to 1/3 in many of the surgeries, and patients can jump back to their life.
Now, we already spoke about fusion surgeries. What are non-fusion surgeries?
Non-fusion surgeries are some surgeries in which we try to keep the mobility of the spine, and at the same time not compromising the correction of the pathology. Non-fusion surgeries include total disc replacement because it allows mobility. It also includes surgeries like discectomy and decompression surgeries, laminectomy, foraminotomy, laminoplasty, and also the interspinous spacers. So any surgery in which we are not doing any fusion, we are not putting bone graft, we are not putting screws and rods, any cages.
So what are the benefits of having some of these surgeries? I mean, will you be cured once and for all, or does the pain come back? What's the benefits of it?
So again, the surgery is not for everyone, but patients who are not getting relief with any other treatment modalities, who need treatment, who need to work, who need to get back to their life, they need a cure to the pathology. Now, surgery helps taking that cure in sort of a permanent way. That does not mean that they will not have any spine problems in the future. The surgery in itself may cause some degeneration, but at the same time, body is still aging. The degeneration will still happen at the segments above and below, and if we have not done a fusion which has been successful, then at the same level also. So these patients can have problems in the future, but we are talking about taking care of the problem right now at this time, as they are not able to continue without any other treatment modality, actually.
And that was my next question would be, what are the risks? We spoke of the benefits of back surgery. What are the risks for back surgery?
Like any other surgery, every surgery has its risks. Lumbar spine surgery has its risk. The common risk with any other surgery is infection, bleeding, injury to the adjacent nerves and vessels. But again, we are working right on the nerves, so we can cause deterioration of some of the neurological problems. We can cause some tingling, some short-term pain, which may need some treatment. We work very near to the sac where the nerve roots are, so we may sometimes injure that, cause leakage of the CSF, in which case we actually repair them, and most of the patients don't have any problem, don't need any secondary procedures. But there's always a chance that we may need a second surgery. Occasionally there is a chance that we have injury to the adjoining facets, they get degeneration, they may need future surgeries. But all in all, a back surgery is a very successful surgery. People do get better and they get back to the normal living as soon as they are healing there.
And again, to put people at ease, this is not the surgeries that were even performed 10 years ago. The new technology that's out there, we had spoke about previously with the MRI. Now they're working on this thing with the sonogram, okay, where they do this and they place the needle and you don't even feel it. It's actually really incredible, and it's much, much safer than surgeries that were done 10 years ago. And most of the surgeries now, like we were saying, are outpatient surgeries where people are thinking, oh, well, I'm going in Monday, I'm not coming back for a month or something. That's no longer the fact, right?
Yes, exactly. With the enhancements in our visual optics, we use magnifications, loops, we use sometimes microscope. At the same time, we use intraoperative fluoroscopy, which are like x-rays we take inside the operating room to see where we are, what are we doing, where are we putting the screws and rods. Also, we have the capability of doing intraoperative CT scans. So we can do a CT scan, especially if the patient has a crooked spine. We try to do a CT scan. We can put screws according to what it shows on the monitor, which is called a navigation. Also, in the recent advances, robotics have come into the spine, in which we template everything into the software preoperatively before the surgery, and then we use the robots in the surgery, which guides us as to where to put the screw, where to put the rods, which gives a very optimal result.
And so you talk about this cyber knife and robo knife and stuff like that. Is that what
Yes,
these are?
exactly. That's we use the robotics and these on the spine, which have been traditionally used on the brain.
And again, to put people's fears at ease, there's not going to be some robot that's standing there with a couple of scalpels. The doctor is there. Everybody's around. The computer really, and the robots do the cutting through the assistance of the doctor and everything like that, right?
Exactly. The surgeon is still scrubbed with the surgery. The robot is only there to help the surgeon. The drilling part, putting the screw part is all done by the surgeon himself. But the robot helps to guide, and there is a fail-safe on it. We do check it at that time also live in the OR as to we are not doing anything wrong. And these things have been tested and researched over time to find that their accuracy rates are far above 99% before they are even implemented into the operating room.
And so people can rest assured that if they're going for something like that, it's because also the precision of these robots, cyber knives, stuff like that. Now, I believe that they use sometimes laser scalpels or something. I mean, it sounds like something from Star Trek.
We do use ultrasonic scalpels actually, which is what we do when we have to cut the bone. We do use ultrasonic scalpels. They make sharp cuts. They make surgery easier and quicker. That helps us taking the patient in and out of the OR very quickly, and they tend not to injure the adjoining soft tissues and the dura from where the CSF can leak, and they help a lot.
What advice would you give to somebody who's about to have a back surgery? What can it be, anything to calm them down or anything? Or you must get this all the time with patients. What do you usually tell them?
So as a preparation, first of all, they should have usually taken a course of conservative management in the form of medications, physical therapy, sometimes injections. And if they have failed everything, then we talk about the risks, the benefits, the complications of a surgery. What are the treatment options other than surgery, and how they can fold out to them if we take one path or the other. There is also regarding optimization of a patient before the surgery. They should have a good nutrition. They should have a good hemoglobin in their body. Their albumin should be good, so that means that they will heal well. We preferred they should not be smoking, even if they are using nicotine in any form, like vapes, cigarettes, cigars, patches. We discontinue them before the surgery. Especially if we are doing a fusion surgery, it is imperative that they should not be using nicotine in any form.
And why is that?
Because nicotine hampers healing, bony fusion, and the the chances that someone using nicotine failing a fusion are very high. So unless it's an emergency and we cannot, we will do a fusion, but otherwise electively we would try not to do a fusion surgery on a patient who is using nicotine.
Wow, that's really something else, because we found out all these things about smoking. Now we're finding this out too.
Yeah. And smoking also enhances the degeneration of the spine. So it is one of the causes of back pain now. So apart from that, we would also see that the patient has, if the patient is overweight or obese, we would like them to have some weight control in the meantime when they are doing physical therapy, and also that helps optimize their recovery after the surgery.
Exactly. And like, just to repeat what we said in the last program about weight, was that, your spine is designed just like, let's say a truck can hold 250 pounds. You're throwing 500 pounds on this thing. Sooner or later, something's going to break, a shock absorber, something's going to go down on that thing.
Yeah. Increased weight is a major cause of advancing arthritis, not only in the back, but also in the hip, in the knees, in the foot. And control of weight, decreasing the weight, is one of the very good treatment modalities to actually control your pain in musculoskeletal, that's the spine and the hips and the knees.
Well, Dr. Vaksha, we're out of time for this episode, but will you come back and tell us about the neck and the neck problems? We pretty much covered the back on this one.
Yeah, it was nice being here.
Okay. Until next time, we'll be back again with Dr. Vaksha on this channel. Stay tuned and take care.
I'm Vedant Vaksha. I work with Complete Orthopedics. We have offices in Stony Brook, in Little Neck, and in Babylon, and I can be reached through our website, cortho.org, or through our phone number, 631-981-2663.